time, and as we have an outside speaker
like that?
today, I'm going to
Right, and if you want, you can just, the clip is there, do you have pants or
Yeah.
things?
if we can get us started, I think that'll
Be
keep
in
us
a
on
dressing
time.
room, right?
I know.
I just wanted to remind everybody from a CME standpoint that we really
No, I got
would
it.
like you to sign in to our website.
This mic
And
is
the way
for
you
the
do
room.
it is based off of this. So even if you are a student or resident, but you don't need CME credit.
Clip that one on too.
Sign in to our website because that's how we count our numbers.
And don't go
and
through
it helps
any
us keep
airport
our
terminals.
background. Also, at the end of the session,
That
you'll
would
be sent an
not be the first time I got in
evaluation
trouble at the
form,
airport.
and it's really important that you help us fill that out, because again, that's how we maintain our accreditation. Without much further ado, I am going to have Dr. Will Dodd, one of our general pediatricians, who's also our adolescent medicine physician, introduce our speaker, Dr. Anna Tanner.
Okay, thanks. I'm good, yeah.
All
Thanks,
right,
guys.
so today it's my pleasure to introduce Dr. Anna Tanner. Dr. Tanner has come up from Atlanta to speak to us today. Dr. Tanner earned her medical degree and also did her pediatrics residency at Vanderbilt University in Nashville, Tennessee. She then moved to the Atlanta area where she sounds like she was a pioneer in adolescent medicine and also became interested in eating disorders. It has been instrumental in forming this, the Veritas Collaborative, about which she will be speaking today. Dr. Tanner is a fellow in both the American Academy of Pediatrics and also the Society for Adolescent Health and Medicine. And she is also a certified eating disorder specialist with the International Association of Eating Disorder Professionals. She has numerous talks and numerous publications in this area, and I really look forward to hearing what she has to say about a very important and surprisingly common problem.
Thank you, Will. That was great. Appreciate it. All right, can everybody hear me okay? All right, so first is I'm the world's most casual speaker, and I tend to roam, so I hope that's not a problem. And two, I really want you guys to feel like you would recognize a patient with an eating disorder after this talk today. So please stop if I'm not being clear or you're thinking of a clinical scenario and you want to make sure that you're seeing this through the right lens. Does that make sense? I really want you to get something out of this because eating disorders are very, very prevalent. When I was in your shoes a long, long time ago and I was kind of sleep deprived and I didn't know what to answer when I was getting pimped, right, in rounds, the answer in my days of training was always tuberculosis, right? If you didn't know what a patient had, pretty good chance like TB could be on the differential diagnosis list. Well, eating disorders are the TB of your generation, okay? If you don't know what's going on with a patient, there's a pretty good chance it could be an eating disorder. So this diagnosis should always be in the back of your heads. We're going to focus on kids and adolescents. Almost all patients with eating disorders present before age 25, so they're going to land in this age group. So is that a good place to start? We're good? Okay. Here's my disclosure slide. I have nothing to disclose. And thanks to everybody here who helped make today's talk possible. So here are your learning objectives. We're going to talk about how eating disorders are a mental illness, but with serious medical complications. We're going to talk about how you should be able to diagnose an eating disorder and do a very targeted history and exam on these patients. And we're going to talk about how to manage the most serious medical complications. So we're going to cover a good bit of ground, but luckily I'm a Yankee, so I'm going to go really fast. Okay. Eating disorders are lethal. They're one of the most lethal psychiatric illnesses we see. My guess is you guys can guess what past eating disorders for lethality in the last couple years. Do y'all know what's the most lethal mental illness right now? Statistically? Yeah, the opioid epidemic. So up until a couple years ago, eating disorders were technically the most lethal mental illness. Now it's the opioid epidemic. Most of the deaths come from starvation. A lot of people think that most of the deaths are from suicide. Suicide rate is very high in this patient population, but most of the deaths are from medical complications, which is why it's so important that you all are learning about these patients today. Every single organ system can be affected by eating disorders. So if you like Sherlock Holmes, does anybody in the audience like Sherlock Holmes? Okay, this is your disease, okay? Because this is a trail of tiny clues that point you in the direction to this is what's going on with the patient. Even if you don't like Sherlock Holmes, you'll still like this illness. Okay, and eating disorders are really important because they have potentially irreversible effects. So a lot of times we think about the effects of starvation reversing, but they don't all reverse. And we're gonna spend a little time talking about that today as well. Eating disorders are not a willful illness, okay? So that is very old. That's a lot of the shame and stigma associated with this illness, but that's not true. These are unbidden mental illnesses. Parents don't cause them. Kids don't ask for them. We don't really know what triggers them, but they're very, very, very genetic. And then there seem to be some personality and societal factors that kind of load that gun. Eating disorders can be present in patients at normal weight. In fact, most of our patients that we see are at normal weight. So if you're only looking for underweight patients, you're going to miss most of your patients with eating disorders. Eating disorders can affect patients of all genders, gender identities, all ages, so children, adolescents, and adults, people of all ethnicities and all backgrounds. So for example, my assessment clinic that I run in Atlanta, we see 10 new patients every Tuesday. They see a multidisciplinary team. The spigot is wide open for that assessment clinic. And we are right by Gwinnett County, which is the third most diverse county in the United States. We see every single type of family and child that you can imagine in that center. Our youngest patient currently is 5 years old. We've had parents speaking several dozen languages already, so we have a very sophisticated translating service we use. In children and adolescents, it's really, really important to start the beginning of this talk thinking about that these kids are going to show up with issues with growth or puberty and not the same way we think about them in a kid who's done growing. So just some general statistics to frame incidence. We think that anorexia affects about 0.5 to 1% of adolescent girls, so about 1 in 100. Bulimia, about 2 in 100 adolescent girls. Statistics on boys are really lacking, but we think eating disorders are much more prevalent in males. They're just often under-detected and under-diagnosed. General statistic, we think about 14% of the total US population is affected by an eating disorder, and that's all of the eating disorder diagnoses. The new age of onset is 12.3 for anorexia, 12.4 for bulimia nervosa, and the average age of diagnosis for ARFID is 11. So these illnesses are affecting very, very young patients. Those rates make eating disorders the third most common chronic illness in adolescents, behind acne. Okay, so think about how much acne you see. Okay, and now think about how many cases of eating disorders you're managing. We're seeing a lot more eating disorders in even younger patients. We're seeing a lot more eating disorder cases we're diagnosing in boys, a lot in the LGBTQ population, and a lot, as I spoke to earlier, in minority groups. So this is the Minnesota starvation experiment. Who knows what was happening in 1945? Bingo, the war. It was a little thing called World War II. Okay, so across Europe, people were starving. And we would go into towns and we would liberate communities, and well-meaning soldiers, right, they would take off their rucksack and they would give their MREs to people in the community. And people would die in front of them that were starving. So they would eat a whole lot suddenly, and they would die. And we had no idea why that was happening. And so this guy named Ansel Keys at Minnesota got a bunch of conscientious objectors, so men that were mostly Mennonite and Amish. They refused to bear arms, but they wanted to serve their country. And he got them to volunteer to starve themselves to Europe levels over a 6-month period. So these men were on very restricted intake. So these guys are both at a BMI of about 16. That's what a BMI of 16 looks like in an adult man. And they had no issues before they volunteered for this study. And this is what Keys found, is that these men who had no issues before the study, when they starved, they changed a lot. Their personality changed tremendously. They became obsessed with food. They started collecting cooking utensils and collecting cookbooks, talking about food, reciting recipes that they knew by heart. They became irritable, they became forgetful. He was the first person to show that when your body starves, your blood pressure drops and your heart rate drops. And these men became anemic and they developed edema. The other thing that was really interesting is that in this study, he gave them 6 months to starve and then 3 months to refeed. They had no limits on food or rest. Those men were not well at the end of 3 months. They had not restored their weight. They had not restored their vital signs. They had not restored their labs. And so what they found was that the recovery process from that kind of starvation was very, very long. long. A lot of these men had long-term medical complications that they never resolved completely. And the other thing is that he showed that hunger and fullness cues go away with starvation and can take a very long time to come back, and sometimes they don't come back completely. So some of the things we now see in our patients that are presenting with acute starvation dates back to this research in 1945. Does that make sense? Okay, so now we're going to go to now. So this is the DSM-5 list of eating disorder diagnoses. Has everybody heard of the DSM-5? Okay, so the DSM-4 had 3 diagnoses for eating disorders. Does anybody know what those were? Anorexia, bulimia, yep, EDNOS, eating disorder not otherwise specified. It's very, very, very hard to study anything in medicine when you lump a bunch of stuff together, right? We don't have, in the world of cancer, we don't have leukemia, lymphoma, and cancer not otherwise specified, right? How would we ever come up with therapies for treatment? And so with eating disorders, it didn't make any sense that we were using such a broad net. So in DSM-5, we got much more granular, and this is helping us get a lot more data and do a lot better with treatment. So anorexia nervosa and bulimia nervosa are still on the list. Binge eating disorder is now included in the DSM-5. It has its own set of criteria that patients need to meet. There's also this diagnosis, ARFID, avoidant restrictive food intake disorder. Has everybody heard of ARFID? This is my pet illness. So this is picky eating that is beyond picky eating that you've ever seen. These kids don't outgrow it by middle school. They have severe nutrition issues, so they might present with really uncommon medical complications from starvation, from malnutrition, like rickets or scurvy, okay? They may also show up with really severe growth issues or really low bone densities. A lot of these patients have comorbidities like OCD or autism or learning disabilities, okay? So this is a quickly being recognized. We're learning more about these patients. I don't want to spend the whole time talking about them, but they can get in a lot of trouble. Pica and rumination, you guys are probably familiar with. And then there's this whole category here called OSFED, other specified feeder eating disorder. And this is where patients who don't meet these full criteria fall in, okay? So if you have a patient who's starting to binge eat, but it's not frequent enough or severe enough to meet these criteria, they would fall in here. Atypical anorexia nervosa, has anybody heard of that diagnosis? So these are patients with all of the mental symptoms of full-blown anorexia nervosa, except they often are starting as medically overweight or medically obese. And so even though they've lost dramatic amounts of weight, even though they're sometimes presenting at a normal weight or slightly overweight, they have full-blown, mentally, anorexia nervosa. And these are actually the sickest patients we're seeing right now. They're often presenting with 30, 40, 50% weight loss in a very, very short period of time, okay? So don't think this name, a lot of doctors think it means it's less severe. It just has to do with their starting weight and their presenting weight. Does that make sense? Okay. All right, so I am not a therapist. Carrie, don't listen to this part. But I want you to understand a little bit of the psychology behind these 2 main illnesses. So anorexia nervosa is what we call an egosyntonic mental illness, meaning for the patient, the eating disorder replaces their ego state. And this is why they have 0 insight into their behavior. So everything else in life, they're fine. Their relationship with their parents, their schoolwork, everything else they're doing, they're very insightful, they're very, very smart. And when it comes to the fact that they're starving, that they're wasting away before your eyes, they can't see it because the mental illness has replaced their own ego. Does that make sense? And that is what gives them this body image distortion. It's what makes gaining weight uncomfortable and intolerable. It drives their fear of weight gain, and it makes them deny how ill they are. So if you've ever seen one of these patients, right, they're in front of you, they've got a super low heart rate, they have a very low blood sugar, you're trying to explain to them how dangerous it is, and they just can't see it. And this is obviously why treating minors is a little bit easier with this illness than treating adults, right? Because an adult, you're arguing with the illness. With a minor, you can explain this to the parents and they can understand the kid's not going to change their mind. Bulimia nervosa is very different. It's an ego dystonic mental illness, meaning that the patients are very aware of what they're doing, but they have a lot of shame about their behavior. And bulimia nervosa, binge eating disorder, are actually the exact same illness. There's just no compensatory behavior with binge eating disorder, but there is with bulimia nervosa. Okay, does that make sense? Y'all see the difference there? Now, Are either of these groups going to walk into your clinic 5 years from now and say, Doc, I have a problem, I throw up all the time? No, because why? They're ashamed of their behavior. So that shame isolates them, it makes them keep it a secret. What about these patients? Are they going to walk in and tell you that they're only eating 200 calories a day? No, because they don't see it. So you have to remember these patients are not going to come in disclosing their behaviors because of the way the mental illness works. Does that make sense? All right, let's do some medicine. So these are the kind of things that they might come in pediatrics. The parents might say they're worrying too much about their weight. They talk about it all the time. They've changed their diet. Like they're vegan and the whole rest of the family eats steak every Sunday night. They're losing weight and they're continuing to lose weight. They've stopped having their periods or they're not growing. Really, really common, those teenage girls come in and their little sister just grew right by them, right? So they haven't been eating well for a while. And now the little sister's having a growth spurt and starting her periods and the older sister's not. So those are all really common presentations. Medical symptoms, like if you want the official chart of medical symptoms for eating disorders, this is it. So with restricting eating disorders, so not just anorexia, but also atypical anorexia and ARFID, they may come in with weight loss, loss of periods, dizziness, chest pain, palpitations, seizures, very, very common from hypoglycemia or hyponatremia. Fatigue and weakness are common, constipation or non-specific abdominal complaints, fractures, spontaneous fractures, hair loss. What do you guys think is the only one that bothers the teenage girls? What's the only thing that makes them go into treatment? Hair loss. Okay, very good. And then that cold intolerance, right? They come in to see you in June and they're wearing a whole lot of layers. For patients who purge, they're more likely to have irregular periods than no periods. They're also very likely to have palpitations. They can come in over and over again complaining about acid reflux that doesn't get better, obviously, because they're purging. They might also do the same thing with a lot of complaints of sore throat or sensitive teeth or a recent increase in cavities. They might have constipation or diarrhea, depending on how they purge, and they're often going to have edema, and we're going to talk about that more in a little bit. So any questions on those symptoms? Great. So this is the SCOFF. Has anybody ever seen the SCOFF before? This is the most validated tool we have for screening for eating disorders. You can tell it's British. How can you tell it's British? 1 stone. Does anybody remember what a stone is now that Downton Abbey's off the air? No. So it's kind of a harder tool to use. We need to bring Downton Abbey back. But SCOFF, it's good. Okay, do you feel sick when you're uncomfortably full? Have you lost control over your eating? Have you lost 1 stone, 14 pounds? Do you think you're fat when others think you're thin? Does food dominate your life? So if you have a patient who says yes to any of those, that's actually very predictive of an eating disorder. They can be kind of cumbersome questions to ask, but they're actually very validated. Now, how would these questions work with an 8-year-old? Right? Okay, so this is what the AAP says in Bright Futures. We should ask these 2 questions at a checkup or anytime there's a concern. How do you feel about your weight and how much would you like to weigh? What should a 9-year-old answer to those 2 questions? You guys have seen a 9-year-old. Thank you. Can you do that again for everybody? The shrug, right? They should have 0 opinion, okay? If you're talking to a kid and they have an opinion on how much they weigh, that's a problem. If you ask them how much they'd like to weigh and they have a number at all, that's probably a problem, okay? So basically any answer at all other than a shrug is a concern in a child, okay? So when you're doing your evaluation, so a family comes in, they're worried about the kid, you've screened the kid, you talked to him for a little bit, you're gonna kick into your medical evaluation mode. So you wanna make sure it's not something else, and we do a brief screen out, not an exclusive, not an extensive workup. You're getting an idea of where they are psychologically and nutritionally and medically, which will help you determine how severe their condition is, and that'll help you make a plan of care for next steps. So we're just gonna walk through. So differential diagnosis list is long, pretty much anything that can cause weight loss, so GI illnesses, chronic infections, endocrinopathies or cancers can be on there. We do see patients who can present with primary psychiatric issues that are not eating, so but they're not eating anorexia, the symptom, versus anorexia, the illness. But pretty quickly, you guys are all getting very, very good at your diagnostic skills, all right? You should be able to get a good history and do a pretty good physical and rule all of that list out and things like it, Okay, so this is how, these are the things I like to focus on when I'm doing a history. Okay, so really good things. Get a good weight history. What's the highest weight they've ever weighed? What's the lowest weight they'd ever weighed? What would they like to weigh? So if you have a kid, right, who has lost a lot of weight, and they say they want to weigh less, is that probably a concern, right? And when they get to that lower weight, what happens? Are they happy? No. What do they want? To lose more weight. Really good. Okay. Exercise history is really, really good. So we ask these kids, how often are you working out? But not just that, how do you feel if you miss a workout? So these are the kids that are doing doubles, even though nobody told them to do a double. Okay. Who here played high school or college sports? Anybody? Okay. When practice was canceled for rain, what'd you do? You go home, play some Xbox, eat some Doritos. What do these kids do? Yeah, they go for a run or they do a workout that's like 2 or 3 times harder than what they would have done if they were working out with their team. So those are big red flags. They can't stand missing a workout. They do extra workouts. Their current eating habits, so a 24-hour recall can be really, really helpful in these patients, as well as a change in eating habits. So they went vegetarian or they went vegan or they recently started counting calories and nobody else in the household does that. You can ask about a history of binging or purging. That can be really hard to do in a comfortable way if you don't do it all of the time. I typically ask something like, a lot of my patients have at times eaten so much that they felt uncomfortable afterwards. Has that ever happened to you? Some of my patients have eaten so much at times that they've thrown up accidentally or on purpose. Has that ever happened to you? So I'll ask them questions like that where you're kind of normalizing the answer versus putting any stigma around the answer. Does that make sense? Okay. Past medical history, you do want to know if they've ever had an eating disorder diagnosis before or any other comorbid psych issues. You want to have an idea of where they are in puberty. We're going to talk about why in a minute. You want to get an idea of the family's function and resources, especially when we start talking about treatment. That can be really important. And then comorbidities, especially abuse and substance abuse and suicidality. Okay, so let's talk medicine. In my center, we always get post-void gown weights. I don't have any of my patients in here, do I? Good. Okay, why would we get a post-void blind gown weight? Why are we doing all those things? An accurate weight, yep, that's right. So why is it post-void? Yeah, they'll water load. They'll try and increase their weight by water loading. Why is it in a gown? Yep, they hide things in their clothes. Your patient should not be jangling on the way to the scale. That's right. Okay, and then blind. We make them stand backwards on the scale, okay? And you can't write it down in front of them. You can't have a reflective mirror or something across from them. And it's really important because what did we say? Gaining weight is unbearable. So they can't know their weight. We get orthostatic vital signs. We're going to talk about those, and we get a temperature. Those can be abnormal in our patients. We look a lot at BMIs, but remember BMI changes with age, right? Adult doctors don't get this the way you guys get this. BMI changes, right? Babies are here, and then they do like this, and then the BMI increases with age. So it's more important when you're evaluating kids with possible eating disorders to look at things like median BMI or percent median BMI or a BMI Z-score. Okay, so you want to see where they compare to other kids, their age, their height, and their biologic gender, and put them on the curve that way. I do look at old growth curves, right? So kids should be growing and they should be gaining, right? So kids should grow about 2 to 3 inches every year and gain 5 to 7 pounds for those 2 to 3 inches every year until they hit their growth spurt. Remember, kids by age 3, right, they're hitting a curve and they stay on those curves their whole childhood until they hit puberty. So they should be steadily on a percentile for weight and they should be steadily on a percentile for height. And our patients, if they stop gaining weight, what happens to their growth? They'll stop growing, and so you'll see our patients, they're gaining, their weight goes like this, and then within a year their height goes flat too, okay? And there's really good evidence that they do not get a chance to regain that height. The height that's gone is gone, okay? We'll talk a little bit about the physical exam and some of the things you might see. So on physical exam, for patients who are energy insufficient, so any of the restrictive eating disorders, so anorexia, atypical anorexia, ARFID, they can come in with low body temperatures, low blood pressures, low heart rates. They have very dry skin. They may have very brittle nails. They get lanugo. Do you guys all know lanugo? What's lanugo? Those fine downy hairs. Where do the teenagers get it when they're starving? They get it on their face. Yep, right here. And where else? Their arms right here. Where do the little kids get it with acute restriction? Down their backs. Like the kids you know how in the nursery you sometimes see the kids with the lanugo in their back? That's what the younger kids do, okay? Acrocyanosis, so these are the kids come in with cold blue hands and cold blue feet. So it's June and they're in their flip-flops and their feet look like a corpse, okay? That's these kids. They can get edema. They get a lot of mitral valve prolapse murmurs, so if you're good at hearing this murmur, this is a good patient population to listen for it in, because as they starve, the heart shrinks, but the valve stays the same size. So you'll hear that mitral valve prolapsing. And they get blood pressure and heart rate changes with orthostatics. For patients who purge, Russell's sign is going to show up on one of your exams somewhere, but we never see it anymore, okay? So we used to teach that patients, when they purged, would use their fingers and they would get a callus, right? So they're very ritualistic about it. They would always purge with, say, these two fingers, so they'd get a callus right here. Why do you think I never see calluses anymore on my exams? I think somebody said it, the internet. So they all Google how to avoid detection, and the Google tells them they're going to be looking for those calluses. So most patients now use a spoon or a pen or a toothbrush, which means that they can swallow it, which Peds GI loves, okay? Or occasionally, I've had one patient with OCD who liked to use her fingers, so she kept a chart of which finger she used and she rotated through all 10 fingers, so they were equally calloused, so it wasn't so obvious. So it still shows up on exams, but thanks to the internet, you'll see it less. They will get hypertrophy of these glands, okay? Typically, you're not gonna see the hypertrophy though until they stop purging, right? When they're purging all the time, they're using the gland. It's only when they stop that you'll see it swell. So if you have a patient who tells you they're throwing up 20 times a day and their face is not swollen, you should still believe them, okay? Guess what's gonna happen to their face when they stop throwing up? That's when it's going to swell, okay? They can lose the enamel on their teeth, especially the surfaces that it splashes against, so those upper molars and the backs of the front teeth. You'll see a lot of like cavitation and loss of enamel. They'll have a lot of ulcers in their mouth and abrasions in their mouth, as well as cavities. They can also get edema. And then sometimes you'll hear a cardiac arrhythmia if they're in an arrhythmia. Not so common, but you might. Okay, labs are almost always normal when you first see a patient. Okay, if you see a patient and their labs are abnormal when you first evaluate them, here's my Dr. Tanner tip. You should freak out, okay? Because they're in a compensated state when they present, okay? Your body wants to maintain you in balance no matter what you're doing to it. So the body is compensating until we try and take away the behavior. And then we see how sick they are. But we usually get CBCs, a CMP with MAG and FOS, a UA, and thyroid studies. You should get an EKG in almost all of your patients. We'll talk about those heart findings. You should consider DEXA in most of your patients. Right now, the AAP criteria for DEXA differ from the Academy of Eating Disorders. The Academy of Eating Disorders recommends all males at presentation, all females with 3 to 6 months of amenorrhea, and all formerly obese patients. And what I'll tell you is, especially with the patients with ARFID, we're seeing very abnormal DEXAs in patients where you would not suspect it. I'm getting ready to write up a case series with the team at Harvard over this. So you liberally use those DEXAs, and you want to look at a Z-score compared to their peers, okay? If you have any concern about GI illness, you might want to get a SED rate, a TTG, IgA when you're getting labs. If you think they're purging, you might want to get an amylase and lipase. They're rarely abnormal. And if they have amenorrhea, you must document a pregnancy test, right? Thank you, Adolescent Medicine 101. But you might also want to get hormone studies. Remember that LH, FSH, estradiol, or testosterone will be very low. Okay, good. Any questions on labs? All right, so when you do your workup, so you get your vital signs, you get your labs, you're gonna find some very unstable patients, and that's why it's a good thing that you work at a hospital, okay? So in 2003, something unprecedented happened. The American Academy of Pediatrics and the Society of Adolescent Medicine agreed on standards for hospitalizing these patients. I've never seen them jointly publish policy statements before or after. This is the only time they ever did it. If they did it, does that mean it's important? Yes, okay. So this is what the 2003 standards look like. So for patients who are restricting a heart rate under 50, a blood pressure under 90, a body temperature under 96, or significant orthostatic vital sign changes, these are important too. Refusal to eat or very low weight, losing weight even in treatment. For patients who are purging, very low potassiums or chlorides, being unable to stop throwing up, abnormal EKGs or arrhythmias. Now, there was a big problem with this tool, so it's been updated a couple times since. I'm going to show you what the most current version looks like, and you tell me what they changed that made it easier to use. What did they change? I'll go back. That's the old one. Here's the newest version. They didn't separate it out, okay? So I gotta tell you, pediatricians sometimes were knuckleheads. So if a patient said they weren't eating, but they didn't admit to the purging, the pediatricians were looking at this. And if they were restricting, but one time they threw up, the pediatricians were looking at this. So we were not stabilizing a lot of very ill patients. So what we've done instead is we're no longer asking pediatricians to diagnose the mental illness. We're just asking them to screen for mental instability. That makes sense, right? So it's still the same cutoff point. So it's still that low heart rate, low temp, orthostatic changes, low blood pressure. But we've also added more things, like if they've stopped growing or developing, they need to be inpatient. If they are dehydrated, they need to be inpatient. If they're refusing to eat, they need to be inpatient, okay? All right, in 2003, Ellen Rome, my hero, wrote a great article, and she said, we're not gonna get better outcomes in children and adolescents until we do a better job with early detection, early intervention, and getting these patients weight restored quickly, even if it means that we need to hospitalize them. I saw Ellen a few weeks ago, and I said, Ellen, what are we gonna do? Because we're still not here, and it's been 17 years. She's like, I don't know. So it's good that you guys are studying this. But one of those key points, though, is using the medical admissions to get that weight restored, like our patients from our first study. So when they're coming in, you're going to use nutrition to help with their malnourished status. You're going to use psychiatry to evaluate for comorbidities. You guys, as residents with your hospital service, you're going to manage those medical complications, and then case management will be helping you place the patient in next steps for treatment. So we're going to run through the medical complications and just a little bit on the management now. So if a patient's restricting, it makes sense. Their medical complications are going to come from starvation. And if they're purging, the medical complications are going to come from their method and frequency of purging, right? Seems obvious. So this is the lady. Has anybody ever seen this slide before? It's a government slide. You can all have it for free, and when you give this talk later in life, you can use that slide, okay? But it's a good slide because it reminds you that the whole body is affected by starvation. The most impacted system with starvation is the cardiovascular system. When you lose weight, you are losing muscle. Everybody thinks they're losing fat when you lose weight, but a whole lot more of your mass comes from muscle. And so our patients, as soon as they start restricting, start losing muscle. What's one of the biggest muscles in your body? Heart, okay? So we know that these patients lose heart mass, okay? Sometimes in a way that we can actually measure on echo, but most of them don't have a baseline echo. And what we know is as they lose heart mass, that heart becomes more weak. Their blood pressure decreases, they can generate less output, and their heart rate decreases. Does that make sense? So we see low heart rates with low blood pressures, and they get orthostatic changes. So the heart becomes so weak that when you get your vital signs lying down and then they stand up, what happens? The heart rate increases and or the blood pressure drops, okay? That's not normal. These patients also get tachycardia with very simple things. If you ask them to walk across this room and back, they would get tachycardic. When you go to round on them and they get anxious, they're going to get tachycardic. We had one patient at Children's Healthcare of Atlanta who had a heart rate in the 30s, and every time she brushed her teeth, her heart rate went to 180. Okay, it was that much work for her body, for her to brush her teeth. The heart was that weak, okay? So we had to turn the alarm off when she was brushing her teeth. This is not an athletic heart, right? What do vital signs look like in a patient with an athletic heart? So somebody who's an Olympic level rower. They have a lower heart rate, but what do they have? They have a normal blood pressure, they have great cardiac output, and they don't have orthostatic changes, and they don't get tachycardic walking across the room or when they make you nervous. So just because they're running 20 miles a day, they have hypertension and amenorrhea and bradycardia, that's not an athletic heart, okay? These patients are at risk for sudden death. Okay, this is where most of our mortality comes. We know that once patients get low heart rate variability, that's when they're at the most increased risk of death. So if you ever get a Holter on one of these patients and they read it as low heart rate variability, that's a very, very ill patient. This is also why sometimes when they get really, really sick and you're seeing those really low heart rates and low blood pressures, they won't even be able to mount orthostatic changes. Their heart rate will be 30 lying down and it'll be 30 standing up. You should freak out, okay? You should be calling me that day when you see that patient. We used to think that prolonged QTC was caused by anorexia. We now know it's not. So if you see that, run through your diagnostic list of QTC causes. Because the heart is so weak, these patients are at risk for cardiovascular congestive heart failure. So do you think you should give them a lot of fluids for their low blood pressure? No. Okay, please stop the ER. Do not let them do that. The other thing that happens is when we give them food, okay, you make insulin. Does anybody remember something else that insulin does? Causes fluid retention, okay? So if you have a patient who's at risk for congestive heart failure and you give them a bunch of food and they make a lot of insulin, they get fluid retention, and that causes something called relative tachycardia. So this is where a lot of children's hospitals get duped, okay? So the patient comes in here, their weight's really low, their blood pressure's really low, their heart rate's really low, and the kid freaks out. They're like, they're on to me. So they eat a whole bunch that first night. The next person on the service comes to round the next morning, blood pressure's still low, but the heart rate's up and the weight's up. The weight's up because they have edema, and the heart rate's up because they've got a little bit of congestive heart failure. They've got this relative tachycardia. A lot of less sophisticated children's hospitals send these patients home that next morning. They're in congestive heart failure, so don't fall for that trick, okay? You guys got it? Don't fall for it. They're going to be mad at you. They're going to say it's better. If you watch them another 2 or 3 days, that heart rate's going to fall again as they get that washout. The GI system, very, very affected by starvation. It slows down as well. The colon slows. They get a slow transit constipation. Miralax is safe to use in these patients. Obviously, a high fiber diet is going to make them miserable because the colon is weak, so don't do that. A lot of these patients need more liquid calories, so this is where NG feeds and supplements do well. The stomach also becomes weak, okay? When they try and eat more, they're going to tell you they feel really full, they feel really bloated, they're having a lot of belching or gas or bloating. That's for real. They get a functional gastroparesis. So it's why we put them on small meals with snacks and a lot of liquid calories. And it's why a lot of them will need, a lot of our very, very low weight patients need continuous NG feeds to get well because the stomach just can't do that work at first, okay? But the only way for them to get well is to put food in there. We have hospitalists at our sites, so we'll use sometimes some prokinetic agents when it's really, really severe, but you have to be careful with those with the cardiovascular complications. Our patients often come in with elevated liver enzymes. So think about this. When you're starving, what's your liver's job, right? You guys all just ate lunch, right? You're using some of that sugar now. Where's the rest of the sugar going? Storing in your liver, okay? So then you're going to be working this afternoon. Your blood sugar is going to start to go down, and what's your liver's job? Release that sugar, right? Okay, if you're not eating enough and you're starving, is there any extra sugar to store in the liver? No. So the liver dissolves itself during starvation. It's called apoptosis, selective cell death. So the liver sacrifices itself for energy. So you'll see smoldering liver enzyme tests in these patients. You'll see ALTs and ASTs in like the 30s and 40s, and it goes on and on and on as long as they're starving, okay? The other thing that sometimes happens is we'll have services that feed these patients too robustly or with too high of a carb-protein blend, and then the liver can't tuck away all that sugar fast enough, and they'll get something that looks like a fatty liver. They'll have a big jump in their enzymes. Do not tell them they have a fatty liver. They will freak out, okay? I will come red rum you guys if you do that, okay? Do not do that. Don't do that one. Okay. A couple more things. Endocrine, they get euthyroid 6 syndrome. The thyroid turns itself down to save energy, so it slows down the metabolism. They have low blood sugar, which we just discussed. The body takes growth and puberty offline to save energy in growing kids. In kids who are in puberty, that HPG axis gets turned off, so they stop making estrogen or they stop making testosterone, and that means that they can't build bone, okay? Does that make sense? So I just want to talk about bone and growth for 1 second because there's really, really new research. So just 3 weeks ago, this paper came out in the Journal of Adolescent Health and Medicine. Neil was the lead author, but they looked at 27 different studies that looked at growth. And what they found is that some patients have catch-up growth, but not everybody, okay? And that the younger the patient and the longer they were ill, the more likely they were to have a long-term impact on growth. And that makes sense, right? If the body turns off growing as a way to save energy, those patients are going to lose growth. So especially in younger kids, you're more likely to see them stop growing than to have abnormal vital signs or abnormal blood work, okay? So don't wait until their vital signs or their blood work is low. Look for them to slow down in growth, and that is when you can't wait any longer for treatment. Does that make sense? Okay. As far as bone, there are a lot of problems with bone and the restrictive eating disorders. So when you're not making estrogen, when you're not making testosterone, you cannot build bone, but you're also making a lot of stress hormones. So in the old days, back when I was young, we used to give these patients birth control pills because if they weren't making estrogen, we'd give them estrogen, it would help their bones. It doesn't, and that's because when these patients are starving, their brain goes into fight or flight. Okay, have you ever noticed that they're like still running 20 miles a day, even though their BMI is very, very low? That's because the brain is going into a very primitive fight or flight reflex. It's trying to keep them alive, it's trying to keep them going. And that stress hormone not only keeps them going, it keeps them from building any bone. Also, as they have a lower weight, there's lower mechanical loading. So they're not building bone when they're very, very ill. And remember, what did we say the average age of onset was of anorexia? 12.3, okay? From 12 to 18, you build half your bone density for life. So what's that mean for our kids? They get in a lot of trouble with their bone. Does that make sense? Am I explaining that okay? One last study. Last spring, Mumford published a study showing that bone does not catch up. So we used to teach that when we treated patients with eating disorders, that they would catch up with their bone density. What Mumford showed is that the bone that is lost on presentation is gone forever, and while you wait to get treatment and weight restored, they're continuing to lose bone, okay? And so Catherine Gordon, who's the world's expert on this, said this is a wake-up call. It means we need to be treating eating disorders very differently. They're another reminder of why we want them to get on the road to recovery as soon as possible. Okay, so that's where you guys can be very, very helpful. The brain is impacted by starvation. Does anybody here think teenagers act super smart to start with? No, okay, this is not good news for teenagers. So patients, when they're starving, have cognitive deficits, like we saw in our men in the KEYS study. They're at risk of Wernicke's encephalopathy, so they can be thiamine deficient when they go to eat again. But they also lose gray matter and they lose integrity of their white matter, and as a compensation, they get enlarged ventricles. And there's some studies that show that teenagers do not recover from that. So we know in adults, once their weight restored, it takes 3 years for their gray matter and white matter to come back after weight restoration. There's some evidence that in teenagers, they do not have a complete restoration of what they've lost, okay? And they can have ongoing cognitive deficits related to that. Hematologically, the bone marrow turns itself off to save energy, so they can come in with leukopenia, anemia, thrombocytopenia. The thrombocytopenia, I'm going to guarantee this is the scenario you're going to see. It's always a girl with a pony who's had a bunch of fainting that comes in with a low platelet count. Always, okay? Call me when you see it. It's not a good combination. And then metabolically, they have low temps. They get high cholesterol levels. Does anybody know why they have high cholesterol levels? Good, because we don't know, okay? We don't know. But cholesterol seems to stay in the circulation with starvation. And then they're at risk of refeeding syndrome. How are these guys with refeeding syndrome, Will? They know it pretty well? You guys know this cold?
In the hospital.
Okay. Yeah?
Get to review it.
Have you guys heard of refeeding syndrome? Okay, so refeeding syndrome, when you don't eat enough, you're not only not taking enough food, you're not taking enough electrolytes, including potassium, phosphorus, magnesium, okay? When you go to eat, your body is very damaged and it wants to heal itself. This is the simplest way to think about it and explain it to families, right? The body wants to heal. And the way your body harnesses energy to heal is with ATP. And P stands for phosphorus. See, you guys still remember your Krebs cycle. Very good. So what happens is that phosphorus level in the blood is fine while they're starving. And as soon as they go to eat, the body wants to use all the phosphorus it has to harness that energy to heal. And there's not enough. And it suddenly moves from the bloodstream into the cells. And with phosphorus, potassium and magnesium are moving. And that is not good for the heart. And so that's why you'll see all of those complications. But the most common thing you're going to see is hypophosphatemia and that risk of cardiovascular collapse. Okay, so that's the simplest way to think about refeeding syndrome. These are the NICE criteria for risk of refeeding. Have you all ever seen these before? So these are international criteria on risk. So as soon as you have a patient with any of the first one, they are very, very high risk for refeeding. They should not be refed outside of a hospital setting. So a BMI under 16, 15% weight loss in 3 to 6 months, abnormal labs before they eat, or almost no intake for 10 days. So that might be it could even be like a child safety situation, right? Or 2 or more of this group, a BMI under 18.5, 10% weight loss, low intake for 5 days, or a patient who's abusing drugs, including things like insulin. Have you guys seen any patients who are abusing insulin yet to manipulate their weight? So they're going to come in with DKA over and over and over again. They're losing weight. Their diabetes is not well controlled. Those are patients that are intentionally omitting insulin and they have a lot of electrolyte issues under their eating disorder. Okay. In children are at higher risk of refeeding syndrome. About 38% of children admitted with eating disorders are going to develop hypophosphatemia. It's kind of a national statistic. It's what we see in our children's hospital in Atlanta. The younger the patient, the faster they lose weight. They have no reserves, and the more risk they're going to be. Right now, the number everybody's looking at to predict risk in young kids is that less than 70% median BMI, and that's something that your EMR might calculate, or you might be able to have your dietitians help you calculate. All right, last couple of comments on refeeding syndrome. We used to say start low, go slow, right? Don't start with much more than they're eating, advance them slowly, replace them with things like Fosnac, although some patients need IV phosphorus. Remember, you can't add calcium or vitamin D while they're getting phosphorus. Consider thiamine. And you guys are not gonna be fooled by their weight jumping up or their heart rate jumping up the first day, right? You're not gonna fall for that trick. Okay. Purging, we're going to cover really fast, and then you guys can move on with your day. So purging also affects the whole body. Biggest impact is on the GI system. So patients who abuse laxatives, the colon is not going to function well. Okay, they're going to get a rebound constipation. There is some thought that there's something called cathartic colon syndrome, where with stimulant laxative use, the nerves of the colon can be damaged where it no longer works and has to be surgically removed. It's under hot debate in the field right now. Patients who purge commonly by vomiting are at long-term risk from that esophagitis, and they can even get Barrett's esophagus, so there is some long-term risk from purging. Sinusitis, so that swelling of the parotid glands happens when they stop purging. It's pretty uncomfortable. It lasts about a week. You have to tell them it's going to happen. Or what happens when they look in the mirror and their face is swollen because they're not throwing up. They think they're gaining weight, right? So you have to say, when you stop gaining weight, your face is going to swell. So you can use warm compresses. You can use sialagogues, things like sour candies, okay, to help them salivate. And then we talked a little bit about teeth. I think Mallory Weiss tears is pretty obvious. They can come in acidotic or alkalotic, depending on how often they purge and how briskly they're purging. Recently, we had a patient in Georgia who took 600 laxatives at once. So they can have really, really big acid-base deficiencies. So it really kind of depends on if it's chronic or acute and severity. And with those, they can have electrolyte imbalances too, based on what kind of purging they're engaging in, which can also lead to arrhythmias and volume issues. They're more likely to have irregular periods than no periods if they purge. In patients who have diabetes and they're using their insulin as a method of purging, that can accelerate their complications from their diabetes and make their diabetes hard to manage. But I want to just, last thing, focus on kidney. So patients with exceptional purging can have acute kidney injury. They can have long-term kidney damage. And they're also at risk for Pseudo-Bartter syndrome. You guys heard of Pseudo-Barters? It's my favorite cool thing. Who ordered lunch today? Cover your ears. Okay. The best way to explain Pseudo-Barters to you is this, okay? If you guys all got food poisoning from lunch today, okay, what would happen? How would you feel tomorrow? What would happen? You'd be sick tonight, right? How would you feel tomorrow morning when you got up from your bathroom floor? You'd be dehydrated, weak, dizzy, I think I heard low blood pressure, right? What if you did that deliberately to your body 20 times a day? How would you feel? The body always accommodates. It's the craziest thing. So in those patients that purge chronically and aggressively, they upregulate their renin, angiotensin, aldosterone system, okay? Because their body doesn't want them to be weak or hypotensive or dizzy all of the time. So they start cranking out aldosterone, and aldosterone lets you hold on to salt and hold on to water. So if you have a patient who's purging 20 times a day, and they come in and suddenly they can't purge anymore, what happens? I think I heard it. They get edema, okay? So they get acute fluid retention. We've had patients gain up to 45 pounds in 3 days, okay, in our hospitals. Now, if you've been purging and you have bulimia nervosa and you have a distorted sense of your shape and weight and you gain 45 pounds in 3 days, what do you think your doctor's doing to you? Making you gain weight. This is why patients with bulimia nervosa have a very, very hard time coming into care and getting well, because nobody explains Pseudo-Barters to them or the parotid swelling before they go into treatment. So you have to tell them this is gonna happen before it happens, and you have to help them manage it as well. So when we bring our patients in, we explain to them, your parotid's gonna swell, we're gonna help you with it. It's gonna last about a week. You're gonna get edema. We don't know how bad it's gonna be. It could be really bad. It's gonna last 3 to 4 weeks, okay? This edema can be very, very difficult to manage. And here's the other thing that happens. It seems like suddenly, overnight, those aldosterone levels fall. When they fall suddenly, what happens to their blood pressure? Bottoms out. And so these patients all of a sudden don't feel well. They get up in the middle of the night, they're dizzy, their blood pressure's low, and what happens to them when they get out of bed? They fall. So these patients are actually at really high medical risk for falls, somewhere week 3 to week 5. So when we hospitalize them with us, we know their highest fall risk is actually several weeks into their admission, and we actually check their vital signs more often and assess them for dizziness and don't let them get out of bed until we see that total washout of aldosterone. Does that make sense? Because they can get very severely injured. All right, I'm not going to talk much about these. Just remember, with purging by vomiting, patients are at risk for hypokalemia. You can replace it all you want, but it's not going to get better until you stop the purging. They can also have alkalosis. Remember, if that bicarb is very, very high, they're at risk for seizures, so they might need ICU level management. And then remember, if they drop their magnesium, you're not going to be able to replace potassium. So it's just really important to always be thinking about magnesium in these patients. You don't have to check it as often as the other electrolytes, but if it's low, the potassium will not go anywhere for you. Just a quick note on diabetes and its misuse. So a lot of our patients are deliberately not taking their insulin so that they waste calories, okay? They remember, oh, before I was diagnosed with my diabetes, I lost a lot of weight and the doctor explained that I was peeing out my calories. So they deliberately start omitting doses, but they don't tell anybody it's what they're doing, right? So they go in to see their endocrinologist, their blood sugars are high, what's their endocrinologist do? Increase their insulin, okay? They keep omitting insulin. They go back to their endocrinologist. Their hemoglobin A1C is even higher. What do? increase their insulin. If you bring a patient with undiagnosed bulimia nervosa on top of their diabetes and you give them their full dose of insulin, what are you going to do to them? You'll kill them, right? You'll give them severe acute hypoglycemia. So it's really important to be suspicious of insulin misuse in teens who are having repetitive DKA, really high hemoglobin A1Cs, weight loss with diabetes, because you want to be very, very careful. So we actually take all of our patients completely off their insulin routine. We take them off of their pumps, and we start them from scratch on their insulin routine with low doses and a sliding scale, and they don't get their insulin until after they eat. So we really tightly manage their diabetes for them while they're in treatment. So we've talked about how some patients are going to need acute medical stabilization. While you're doing that, you're going to start restoring weight, you're going to start restoring eating patterns, you're going to correct those acute medical complications, and then you're going to need to get your patient to a team that specializes in eating disorders, right? Because this is not a quick fix, as we talked about with the KEYS study. It's a long recovery, and you're going to need to make sure that the family has support and that they can keep making progress, which is where teams like mine come in. It's really important to know that eating disorders need a multidisciplinary team. So they're mentally ill, so they need a therapist and they need psychiatry. They're not eating or they're having eating issues, so they need a dietitian. And then we talked about how much medical support they need. There are a lot of levels of care. If you've never heard of the levels of care for eating disorders, outpatient is when they visit once a week. Intensive IOP is typically some evening groups. PHP is typically all-day groups. And then residential and inpatient is around-the-clock treatment. Inpatient meaning that they're getting medical care around the clock with around-the-clock nursing and daily medical. So those are obviously services we provide. Okay, that's all I have. I'm happy to take any questions. You guys did great. Almost all of you stayed awake the whole time. I'm happy to take any questions that you guys have. Yeah, go ahead.
Tanner, this was an awesome talk. I just had a question. For patients with comorbidities as well as eating disorders, moderate to severe autism,
Yeah.
Does that limit the treatment options?
It's a great question. So the question is, if they have comorbidities, does that limit treatment options? So you should expect comorbidities. This is a mental illness, and there are patterns typically of comorbidities. So for example, a lot of patients with anorexia nervosa have predating anxiety or have OCD. Sometimes when they starve, those things can get quieter, they actually feel better, and when their brain is well nourished, the anxiety and OCD gets worse and it drives them back into their eating disorder. So it's really, really important that facilities that treat eating disorders can manage those comorbidities. You also pointed out autism. A lot of patients with ARFID are on the autism spectrum. And our kids with autism, the mild autism, actually do really, really well in our programming because it really helps them with their social skills. A lot of them have never eaten at a table or done, an art group or a yoga group. So they often benefit from a lot of components that are not directly related to their eating disorder care, but relate to improving, other social aspects. So you should expect that it's part and parcel of treating eating disorders, that you're treating all of the comorbidities, not just the patient, but the whole family, right? Because when they go home, you all take care of them again, and they're in their family's care. So it's really important that you're giving them skills and their family's skills. It's a really good question. Any other questions? Yes?
Just with patients in general who you don't believe have an eating disorder, but are starting to have kind of more of those symptoms of kind of being either more obsessive about aspects of their weight or more obsessive just in general about kind of how they're treating their body, even if it's somewhat in a positive way.
Mm-hmm. Yeah, so the question is, what do you do with the patient who's starting to have some concerning thoughts or behaviors? So it's really important to remember eating disorders are on a spectrum, right? So some are very mild and some are very severe, and some are easier to get out of, and some are a longer course to get out of. So a lot of people, today's society is very broken, and our teenagers especially are bombarded by messages that are not particularly helpful. So most of your patients are going to experiment with dieting. Most of your patients are going to experiment with aggressive exercise routines, okay? But the brain's natural drive is going to be back towards their body's set point, right? They're going to get up New Year's Day and they're going to work out every day for a month, and then they're going to get sore, they're going to get an overuse injury, and they're going to quit, right? Or they're going to say, I'm only going to eat a paleo diet, and eventually they they get hungry and they go back off it. So remember, that's the brain's natural default. When they get into those patterns though, and it becomes obsessive, when they're thinking about it all day, when they're planning their day around food or exercise or activity, when it starts to limit them socially, where they're choosing that over other things that they used to do, those are signs that they're impaired, and that's actually an eating disorder, mild, moderate, or severe. But when it starts to impair the life they used to live, that's a sign to be worried about. Does that help you?
Yes, it does.
Okay, good. Those are great questions. Anything else? I know you guys need to get on with your day. Right.
And Dr. Tanner and her team are actually going to be here for a few minutes afterwards.
Yeah.
And will help answer questions.
Happy to.
Thank you so much for such a wonderful talk, Dr.
Thank you.
Tanner.
Thank you.
And your attendings have all heard about this too. The team came and talked to us at our faculty meeting earlier this month, and so, or last month, I should say. And so be thoughtful about it, be thinking about it. Ask your attendings if you have anybody that, may fit that criteria.
And remember, if you haven't prepped for rounds, the answer is always eating disorder, okay? All right, y'all have a good day.
Thank you.